is this is week 6. We are now in the middle of the course. I'm going to warn you, it's going to start getting a little tough. You're going to start seeing projects due, case studies due, and exams coming up, and it's going to be hard to keep ahead. So don't fall behind. What little bit you could do every day, go ahead and do it, because it's going to, by week 9, students are like hair is pulling. So you're almost there. So just remember, you're halfway through, you're going to blink your eye, and it's going to be Christmas. Okay, so you're all going to get there. This week, week 6, we turned on the homework grades. So if you didn't do as well as you wanted at homework or missed some sort of project, which actually this class doesn't miss anything. So congratulations. This class, I don't really have to follow anybody. You really do keep up with most of the work, so that is awesome. So homework grades are on for 2 weeks till week 8, and then I will turn them off. I will not turn them back on till after the HESI, till after the remediation. This is just to show you how homework grades can affect your grade, whether it's better it, keep it the same, or maybe decrease it a little. So it's just to let you know that. As we know, there are reviews this week. The first one was today, and we already had people attending it. It's already posted in your announcements. That announcement that has exam 2 review recordings, I will be editing and inserting the new recordings as I get them. And attached to that announcement is the PowerPoint for it. So you have that already. Now, I was sick all last week. When I left you last week, I went downhill and died. And I stayed in bed all through the weekend. On Saturday, I got up, I went to urgent care, got myself a shot of Solu-Medrol. My throat was closing. I was swallowing a Dayquil capsule, and it got stuck, and I couldn't swallow it. And it's right there by my airway. It's like, I know too much, you know? And I was like having a moment. So I just, okay, I need to relax. And I drank a bottle of water as my husband's running for the bread. But I was able to get it down. But that's when I knew I had to get some Solu-Medrol, a steroid for the inflammation. And of course, I was placed on antibiotics.
Thank God you're okay. Oh my God, that sounds horrible.
It was scary. It was really scary. And then when they gave me antibiotics, now I have Augmentin 875 in the house, but they're this big, these pills. So I got Z-Pack, and I got a double Z-Pack because they're this big, and I knew I could swallow them. It is a big difference. Now, you did get an email from Darlene that I had to attach to all the announcements. I want you to know this class is great. I have no complaints. You guys come to class, you're on time as much as you can, coming from community. You keep your cameras on, and I appreciate you all. I mean, that just shows great professionalism and the respect of, I want to be a good nurse, so I'm going to show up. And showing up is what's going to help you make it. I mean, you turn the cameras off, you're not as alert because you don't think anybody's watching you. And it does make a difference. So thank you for being you. But I had to post it on all of the announcements, and none of my classes do I have issues, especially this class. And this week, you have a lot of homework due. You have the congenital heart disease, cystic fibrosis case studies, you have NCLEX questions, and quiz 4. Quiz 4 is directly from tonight's lecture. So you should be able to do okay. I saw one girl last night, literally after class, did the quiz, and she got a 10 out of 10. So, you know, I'm telling me that the information was all covered. So what are we going to do tonight? We're going to be covering oncology, hematology, and a little bit of cancer, immunology, and then we're going to do a cahoots. Now, last night I ran over with lecture, so I couldn't get to cahoots. So let's see if I can compact myself a little bit, because I'd like to get it all to you, you know, in one class. So let's go ahead, let's start with the PowerPoint, and hopefully I don't have too many stories, because that's what takes up some time. But I think those stories really do give you what you need to remember and understand. So hematology. Let's start with that. Chapter 43. Hematology is all about blood, right? CBCs, white count, platelets, bleeding, has to do with all that stuff. And it's your immune system too. You think about lymphocytes, neutrophils, you think about WBCs. That's your immune system, and as strong as your white blood cells, it's as strong as going to be your immune system. So whenever we think of these sort of issues, we're going to be doing a CBC. That's always number one, because we can see the cells. We can see the hemoglobin hematocrit. Is it high enough? Is that why I'm weak and tired? A lot of times you'll get this history and this physical, and part of it's, oh, you're pale, you're tired, no energy. My kid is just not acting the way they should. And that's probably that iron deficient anemia, right? Or one of those anemias. We know as kids get older, their iron that they're eating is not as good. I mean, how many toddlers love to eat a plate of broccoli? I mean, my grandson did. That was his favorite food, which is bizarre. But most toddlers is like macaroni and cheese and some chicken nuggets, right? And you're lucky if you get a little bit of that into them. So they're not getting the iron the way they should. Plus, they're not getting iron fortified cereal, because by the time they're toddlers, that baby cereal, it's not going to cut it. They don't like it. It's actually, if you ever tasted it, it's not very nice. But infants don't have taste buds like the toddlers get. So that's why they eat it and they think it's wonderful. And if we see frequent infections, we see bleeding, we're going to go start looking for it. So red blood cell disorders. So when you don't have enough red blood cells, let's think, what are red blood cells? What do they do? Well, they have oxygen in it, and it carries it to the body, which is fuel for the body. It makes the cells be able to breathe and to be able to get up and go, right? It also carries iron. And again, iron makes you strong. I mean, Popeye, good and strong, and keeps it going. So oxygen and iron are being carried by red blood cells. So if you don't have enough hemoglobin hematocrit, which means you don't have enough red blood cells, you don't have enough oxygen, you don't have enough iron, you're going to be tired. You're going to be lethargic. That's part of what anemia is all about. Now, there are different causes why there's anemia, and I'm going to go into them, different names, and that's the next slide. But we know with children, if a hemoglobin is less than 10, that's what we consider anemic. In adults, might be 9 or 8, we accept. But at 10, children will be getting some sort of iron supplementation. So types of anemia. Well, the red blood cell is all about anemia. So either it's not being produced enough, or it's getting lost really quick, or it's destroyed quickly. So let's look at different diseases and things that go along with that. So decreased red blood cell production. Well, you're not eating right. Nutrition. Think of iron deficient anemia. Most common. Most adults have it. That's the anemia they have. Children too. How do we correct it? Diet or iron supplementation. And the other one that we see is B12. B12 is the intrinsic factor. It's in the stomach, right? And it helps with breakdown of vitamins and food, and it can be entered into the body and be used properly. But then you can also have decreased blood cell production because of bone marrow failure. The big one here is aplastic anemia. And aplastic anemia is the white cells, the red blood cells, and the platelets all have a very low production. And I'm going to go into what that's all about. And of course, they're being decreased produced because of cancers. And then, of course, all of the therapies that go with cancers. Chemotherapy kills a lot of these cells too. And then we have red blood cell loss, which is what? Bleeding. You think bleeding, what do you think? Hemophilia, right? There's also another blood coagulopathy that has to do with bleeding, which actually is only the platelets, not a factor, and it's called ITP, immune thrombocytopenia purpura, ITP. So think of P, platelets. ITP, P is platelets. Hemophilia is a factor. ITP is platelets. So, and I'm going to go into that more. Increased red blood cell destruction. Number one, sickle cell anemia. Now, There are sickle cells, they are being produced, but they die really quick. So your hemoglobin and hematocrit are always very low. Your red blood cells are always very low. Another one that's similar, but it's a rectangular type shaped cell, is called thalassemia. And both of those are due to cultures. We're going to go into that. And then it could be due to either being given that chemo, radiation, or overwhelming affection eats red blood cells. So that could be part of it. So what happens to your body? What do you see with anemia? And what are you going to look for? Well, when you're anemic, you don't have a lot of stuff in the liquid of the blood, in the albumin, in the fluid. There's a couple cells. So they bang off of each other. They go through the heart and they swoosh, causing a murmur. So if we're thinking possibility anemia, we're going to listen to the heart. You hear a murmur, almost guaranteed you're going to see anemia, because that's one of the classic signs. Another thing, you're going to see the heart rate elevated, because the body's trying to get oxygen and iron to the body, but it doesn't have the cells. So as much as it pumps, as fast as it goes, it's still not going to be able to keep up with the oxygen and iron demands, which is the food of the body demands. It just don't. So if we don't correct it, the heart's overbeating, right? It's working hard. It's going to tire out. It's going to ensue cardiac failure. Your heart's going to give up. Now, another thing you're going to see is cyanosis, no oxygen. You're going to probably see circummoral cyanosis. You know, it's all that peripheral, the hands, the feet, because all that blood needs to go to the organs to keep those organs with the oxygen and the iron it needs. And with any nutrition, now remember, red blood cells is nutrition to the cells of the body and the organs. So if you don't have enough oxygen and iron, it's like not having enough nutrition. You will see growth retardation, even cognitive delays, okay? Same thing like nutrition. So you're going to make a diagnosis by doing that history physical, and then a simple CBC, which is going to basically show you the basic what's going on. Now, you get a child in, hemoglobin, hematocrit are really low. They do need to get a blood transfusion. But remember, you're treating a symptom. You're not treating what caused it, okay? So you can continue to give blood, but why is the blood going away? Why aren't there enough, okay? So always figure out what's the underlying. And usually for just support until we get the blood, until we figure out what's going on, we will be giving IV fluids. And all it does, it replaces the volume, the space in the vessels that need to be there so the blood flows throughout the whole body. And there's a question, does oxygen really work? There's no cells to carry it. So will oxygen work? Maybe not. But we're going to put it on anyway, because at least, well, maybe it could, but probably not. And of course, bed rest. And why bed rest? We don't want them expending any energy, because they don't have any reserves. They don't have oxygen to meet those demands of the body itself. So with the assessment, we're going to look at the age of the child, their racial, ethnic background, you know, African American, sickle cell. Thalassemia is the people from the Mediterranean Sea. So these are two different things. Maybe that's what it is. And of course, when you're talking about anemia, we know we have to check blood. We know we're going to be doing needle sticks on these children. So always get on their level, prepare them, make them have fun with it. Use numbing creams. Have the parents hold their child. Use Child Life, distract them, do everything you need to do. Because if we're worried about anemia and we're doing these tests, what's the kid going to do if they're not prepared? You're going to have to hold them down. They're going to be screaming and yelling. They're going to be burning energy. They're going to be burning up the oxygen they need. And this could actually cause, you know, some complications. You see, my voice is still going. But I have my tea. So iron deficient anemia, What is it caused by? Well, in adults, children, it has to do with not enough iron in the diet. Now, young children and infants, we give either iron fortified formula or iron fortified cereals. So they're getting extra. And a lot of them do get vitamins because the physicians want them to have it, and many of them still do. We know adolescents, iron deficient anemia is because they're grabbing a power bar, a bottle of water, running, and that's what they have for the day because they're too fat and body image and they want to feel good, right? So we know adolescents are at risk for it. As a child gets older, gets to be a year old, what do? We switch them off of formula or the cereals, and now they're not getting that extra iron. So they're called the milk babies because now they're just on whole milk because they're not getting the iron anymore. Prognosis is great. We need to treat it. And the treatment is, the cause is lack of proper nutrition, lack of iron in the diet. Replace the iron in the diet, or let's give some iron supplementation, whether it's oral, whether it's that IM dextran Z-track, right? Depending on the child and what the needs are. Now, sickle cell. Sickle cell is those sickle-shaped cells. And what's the thing about those sickles and what makes that a really point to think about a vessel, and it splits in half or in three. And there's that little area where all that bifurcation occurs. That sickle cell has to get through there. All it takes is one to block the entrance, and then everything backs up behind it, right? And then blood doesn't get down to where it has to go. It also causes swelling, tissue death. There's no oxygen, so it's really that shape of the cell, which really also makes this why those sickle crises occur. Plus, we're going to go into other reasons. Now, if two parents have a sickle cell trait, not the disease, just the trait, each child is 25% of having the disease. So, as I said, this is this obstruction of these vessels. Blood can't get through and they're clogged up. Well, how do you unclog a pipe? Well, you turn the water on and try to flush it down, right? So how are we going to treat a clogged up pipe like sickle cell? We're going to start IV fluids, right? And dilate the vessel. And maybe put some heat there, which will dilate the vessel. And then hopefully those cells will start going through because that is the cause of that pain. Now, many students want to say priority action is pain management. No, treat the cause. Put the IV fluids first. Now, in the other hand is the pain medicine, but it's the fluids which is the most important priority. What causes these crises? Well, it all has to do with dehydration, right? Not enough fluid in the body. It is caused by trauma, infection, and fever because you lose, insensible fluid loss, sweating even. You're not drinking enough, not eating enough. Any stress can cause it also. And then if these children are out running around, they're not keeping hydrated, again, that can also cause a sickle cell crisis. So what do you think we need to teach these children and parents? These children must keep a bottle of water, or if they're out playing sports, a bottle of Powerade, Gatorade, and they need to be drinking because they need to keep hydrated. So medical emergency, sickle cell. It hurts. It's bad. These kids whimper, and my heart just goes out to them. So number one, put them to rest. Lay them down and get that IV going. And start that IV bolus as quick as you can. And make sure you keep up with the pain medicine. As I said, they need heat, and they also lose electrolytes. So make sure that we are looking at those values and replacing it. Now, as I said, sickle cells tend to die quick. So actually, I think the highest H&H I've ever seen on a child with a sickle cell crisis, I think was 8 and 24. I usually see it about 5 and 15. It's really low. So these kids come in, they have no oxygen, they have no energy, they're exhausted, and they're in pain, and all of this swelling. So we give the fluid, we give that something for pain, and they're going to be getting some sort of blood replacement. Their hemoglobin hematocrits will be low, and you'll see a lot of times even their platelets. So this is one of those things we're going to manage them from all directions. And any kid with sickle cell is deemed immunosuppressed. These children are told if you have a fever of 100.5, which is really nothing, right? 100.5 or higher, need to get to the doctor. They need antibiotics because there's no immune system. So if it's 100.5, let's treat it now before it gets to be 102. Makes sense? Now, young children are on prophylactic antibiotics for about the first 5 years of life. Well, if they're sickle cell and immunosuppressed, we know the young kids don't have immune systems yet, right? They haven't built it up yet. So giving them that prophylactic is going to help prevent infections and help prevent really bad sickle cell crises. And then they're going to be looking at reticulocyte counts to see how their bone marrow is functioning. And again, the blood transfusion is giving good blood cells to the child or adult, and it's carrying oxygen in it. So this child's going to feel better even after the first transfusion. Now, there's no cure, but we do all the supportive stuff. We teach the parents how to take care of the kids. We teach the children also how to keep well hydrated. If they have a fever, tell mommy. You know, if they start to have pain, tell them immediately so it doesn't become a big pain. And the one thing that we don't think about with sickle cell is sickle cell children can have a crisis in their brain and can have a stroke. A headache on a sickle cell child, you better be checking neurosigns. Makes sense? Because it could be in the brain and it could be that preliminary to a stroke. So that fluid, getting it moving quick, can actually help prevent a child from having a stroke. And yes, children can have strokes. Again, that bacterial infection, if we don't catch it quick, it's that leading cause of death. But children with sickle cell can live, you know, a pretty decent life. Again, early intervention, younger kid, keep that penicillin going. And again, notice if that's in a headache, to pay attention to it and let parents know it, that a headache is a serious thing. And those respiratory problems actually look like almost like a pulmonary embolus. That's how much chest pain they get there. We try to treat these children like they're normal. Yeah, they can play sports, they can go do that stuff, but they have to hydrate frequently, okay? And their coaches need to know they need to be hydrating frequently because that's how we prevent these children from having crises. Now, the other one about blood loss and shortened life is thalassemia. And again, these are rectangles. They're not sickles, they're rectangles. It's from those descendants of people living near Mediterranean Sea. And these cells burst. So the insides of the cells burst into the bloodstream. What's inside a red blood cell? Oxygen and iron. Now, there are 4 types of thalassemia, and it goes from minor up to the point of thalassemia major, and we call that Cooley's anemia. This child or adult is the one that's going to require transfusions to live, whether it's weekly, daily, monthly, it all depends on the physician availability and what this child needs in order to maintain some sort of hemoglobin, so they'll be getting transfusions. Now, when you're born, these cells that we look at in the CBC are moms. So we don't see thalassemia yet. But about 6 weeks of age, we're going to see that change going on. And we're going to see these child hemoglobin hematocrit get lower. And how would we know that? Well, What do we do every visit on any pediatric child? We do a height and a weight. How do you measure nutrition? Height and weight. If they're gaining height, gaining weight, they have proper nutrition. Well, same thing with these RBCs. We don't have enough RBCs giving nutrition to the cells, oxygen and iron, you're going to have a child who's not gaining weight as good. And that will make us go looking what's going on. And then we will see growth failure. Sounds like nutrition, doesn't it? So blood transfusions are given to keep those hemoglobin levels up. But the complication with thalassemia is those cells bursting and all that iron going into the bloodstream. Iron can become toxic. So we give these iron chelating drugs and the desferal. And what it does, it goes in, hooks up with the iron, and you excrete it in the urine in the kidneys. That's it. But sometimes we need to go a step further and we do something called apheresis. It's like kidney dialysis, but you only remove a certain component of blood out of there. In apheresis, in this case, we would be putting them on the machine once a week, once every other week, 2 times a week. Again, it all depends, to remove the iron, because iron can become toxic and could kill a child. So how do we manage it? Well, transfusions and getting rid of the iron, some sort of chelation therapy. These children will constantly be getting blood tests, getting blood transfusions, spend their time hooked up to machines. These kids, it's very hard to have a normal life. The family, the whole family is involved in this. And these kids are getting chronic blood transfusions. So as we get multiple blood transfusions, it's going to be watching out for all of those complications, because when you have multiple blood transfusions, it does change your blood a little bit, and you get these little specific antigens that are hard to match, and you can't get the blood, and you don't get the blood, you don't have the hemoglobin, and you're going to die because you don't have oxygen and iron to the body. Now, treated well, treated properly, they can live, into adulthood, but you're going from being anemic, again, remember, blood cells gone, then you get a blood transfusion. So then it's really good level. And then it drops down. And then it gets good with a blood transfusion. The heart is working, not working, heart working, not working. So the heart is under a lot of stress. So a lot of times they die from heart disease. Now, sometimes to try to stop the body from producing these cells, they'll do a splenectomy. But sometimes, because these are immunosuppressed too, that these children die from post-splenectomy sepsis, overwhelming infection that we can't take care of it. And then, of course, if the body's not getting oxygen, nutrition, you're going to go into multi-organ failure. They think maybe, not sure, bone marrow transplant could be a cure. Now, aplastic anemia is when the body does not make blood products that we need. Now, there's 2 types, but we mostly talk about pancocytopenia, the first one, which is all elements of the blood. The body doesn't make enough white cells, red blood cells, or platelets. Leukopenia is all about infection, white cells, right? Thrombocytopenia, P as in penia, which is platelets, low platelets too. So you don't have hemoglobin, you don't have white cells, you don't have platelets. So what are we going to do with these children? Well, we'll be giving them what we call an immunosuppressive therapy. We're going to try to change the body and make it produce what it needs. Of course, blood transfusions are given as needed. I mean, these children look and act just like leukemia. They're severely immunosuppressed, and they don't have a immune system because they don't have white blood cells, and their body has no energy to fight because they don't have any oxygen or iron in the body. So these children really need to be protected from us. Now, defects in hemostasis, which means you're bleeding. So you think of bleeding, you think of hemophilia, right? Now, there are different types of hemophilia. Now, hemophilia is X-linked recessive, which means mom gives the hemophilia to the child. And once we determine that a child has hemophilia, we will be determining what factor is missing, because it's not just one thing that clots blood, it's several things. So in hemophilia A, it's factor 8. That's the one we think about. You think hemophilia, that's factor 8. And there is a little box with powder and liquid, and you mix it and you give IV to the children, and that replaces factor 8. That's how it's given. It's like medication. And then we have factor 9. And then we have one that maybe should have been factor 10, but the scientist von Willebrand decided to put his name on it. So it's the von Willebrand factor, but it's also factor 8 involved in there. So how do we determine kid has hemophilia? Well, they've got to show you something about bleeding. Now, in my experiences, I have seen children diagnosed with bleeding problems because they come in with bruising or nosebleeds, epistaxis. I mean, and the nose bleeding is not one time. It's chronic. It occurs all the time, which makes the physician go, look, why is this kid bleeding? So, they have the bruising, you see the bleeding, you see bleeding in the joints, and then you say, okay, let's do some lab work. Well, of course, CBC is always number one, but we're going to look at those bleeding things in the blood. When you think of giving heparin, what do we do to test it? We give that APTT, right? We want to see what the heparin level is. Well, in hemophilia, those are elevated. Those levels on your PTT are going to be high. You're not on heparin, you're not on aspirin, it shouldn't be high, and that's your first clue. And then they'll go in and they're going to look at what factor. They'll be going back and drawing a whole bunch of blood to say, hey, what factor, so we can replace it. Now, excuse me, in hemophilia, platelets are fine. It's just the factor. And again, the first thing that we have that clue is that PTT. It's really prolonged. So what do? Well, parents are taught how to give home infusions. I was telling this story to my last class. There was this little boy who came in, I don't know, he was 8, 9, 10, and he had fell down and his knee was swollen and it had blood in the joint, and he couldn't get hold of the hematologist, and he didn't know if he should give the factor or not. He had done all of we do rice, we rest, ice, contain, and elevate when there is any sort of injury, but they didn't know whether to give it. Well, our physician said, go ahead, give it. So the father said, do you mind if I give, my own med, if I give it to the child? And I'm like, it's your kid. The physician said, fine. And I watched his father probably prepare and give it with the son helping him better than I've ever seen it given. And this father and the son had such a great relationship that there was a little butterfly and the kid just held it on the arm. And it was done. The father took it out, had his finger on it, put a Band-Aid on it, and it was nothing. And it was something I'll never forget. I had an orientee with me that day, and she was like, wow, better than me. And I'm like, well, probably better than me too. Now, sometimes we give desmopressin. Now, desmopressin is also given for diabetes insipidus, but that's next week's lecture. So it can be given for both. And sometimes there's a nasal spray, but that's a mild hemophilia, and that's a really rare. Usually hemophilia, you got hemophilia. And then there's amycreproic acid that we can also give. So what do we do? What do we teach? Well, number one, have a safe environment. If you have a toddler hemophilia and you've got sharp, pointed coffee table, you better pad those sharp corners or get rid of it, right? Anything like that, you're going to protect the environment. That's the P in the rice, right? Per rice is the new word. And then, of course, as soon as we see that fell down, bleeding, it's in the knee, we can see it swelling. Stop, rest, put ice on it. It constricts the vessel, will decrease that bleeding. You're going to put an ACE on it, pressure, like putting a finger on something that's bleeding, and elevate it. And then give the home infusion for it. Now, if we do not teach these parents and these children how to protect their joints, they will, because the blood tends to be irritating and will destroy joints. So we want to stop that blood as quick as possible, or these kids will end up in wheelchairs. So we don't want that. We want these kids to be as normal as they possibly can. So there is gene therapy that's coming out. It's not quite there, but it's pretty close. Now, immune thrombocytopenia purpura, ITP. It's about platelets, platelets being low. Now, ITP is something that happens in an acute stage, like getting a cold, okay? But it's this problem with platelets. It usually happens after an upper respiratory, some sort of infection. And what happens is all of a sudden this kid gets nosebleeds, epistaxis. They'll see some sort of bruising, but they're going to see these little petechiae. You see that little purplish thing? Usually these kids, the last one I'm remembering that I saw came in and the mother said, this kid doesn't go out and play. I don't know why they're bruising. And all of a sudden he was sitting there and his nose started bleeding. And you looked at his legs and it had all that purplish petechiae. So we did a CBC. What did we see? Low platelets. And I'm talking 10,000, 15,000, where your low number should be maybe 100,000. So it is quite significant. How do we treat ITP? Well, remember, it's in an acute stage. Look at what the word says, immune thrombocytopenia purpura. So we need to treat the immune system. It's not an infection. It's not a blood thing we need to give. We need to give IV immunoglobulins, boost that immune system, and then we give anti-D antibody. It's another thing that helps with the platelets and letting the platelets start to reform and building up the number again. Usually, if we get this under control within 1 year, it's gone. But it can become a chronic condition. So hopefully it will just be acute. Now, you get a kid in the hospital, has ITP. You as a nurse, how are you going to take care of it? Any patient which has a platelet count that is under 25, 30,000, they're under bleeding precautions because you give them an injection, they're going to bleed. Okay. So we are going to, again, protect the environment. We're going to teach them no shaving. Sorry, you're an adolescent girl, can't shave your legs. Sorry, we're not going to let you bleed. We're going to be looking their gums, looking at their stools, their urine. Is there bleeding anywhere? We're going to be monitoring in the hospital their CBCs. Where is that platelet count today? Is it coming up or is it staying the same? And then sometimes we do use corticosteroids. Now, sickle cell anemia is inside the vessel. That's a bleeding problem. It needs IV fluids. ITP has nothing to do with vessels. It just means you have petechiae, okay? So you don't need IV fluids with this condition. That's only sickle cell. You'll understand in the cahoots later why I just said that. Epistaxis, we know that sometimes that's how we figure these things out, what's going on with these children. So number one, if a kid's bleeding, and of course they think they're going to die because their insides are coming out and they're going to die, right? Calm them down first. Try. Put them in mom's arm, hug them, pinch them, thumb, forefinger, and lean them forward. And we lean them forward because we don't want them swallowing the blood. We'd rather them spit it out through their mouth than swallowing it, because what's going to happen? They swallow blood. They're going to vomit. What's that going to do? It's going to cause you to bleed more. After 10 minutes, if it's not stopped, they need to get emergency help. They need to go to the doctor, urgent care, ER somewhere. Now, a viral condition, immune, HIV/AIDS. Now, we're in pediatrics. So we're concerned of newborns all the way up through adolescence. So with newborns, if we have a mother HIV positive, AIDS, and we have a newborn, they're going to be born, they're pregnant. If possible, if they're under treatment, they should be getting this highly active antiretroviral therapy, which is, an antiviral at 22 weeks of pregnancy. But we need to continue antivirals for the first minimal year of life. And why? Well, newborns are born with no immune system, right? We have this virus in them because of mom. We can literally improve that newborn's immune function. And I have seen newborns become no more HIV by a year old, gone. But it's because we improved that immune system from as early as we could, okay? And it does work. I think that's one of the neatest things that I learned working in the newborn ICU. We can save some kids. And I've seen triplets, one with HIV, one with AIDS, and one with normal. So it can happen, okay? And that was triplets, same mother. Remember with the adolescents, that's the other part of this whole thing, is to make sure that as we're speaking to them and getting on their level and discussing sexual activity, that we give them good counseling. I mean, abstinence is always the best, but adolescents are going to do what they want. So at least teach them about condoms and hand washing even, and taking showers. All those things can help. And one of the most common of all the opportunistic diseases is PCP pneumonia. First time I saw that was in the 80s. I was an agency nurse and I was working at a downtown county hospital in the medical ER. And one of my patients crashed and he had PCP pneumonia. And I'm like, what is that? I had to figure it out, look it up, ask questions. And that was my first time that I had seen it. Of course, now I understand it is, the HIV that causes it, but respiratory, it's going to be PCP pneumonia. Now, treating these hematological, immunological diseases, number one is blood transfusions. It could be packed cells, whole cells, platelets, FFP, it could be anything. Remember, you have some sort of reaction, you spike a temperature or you see a rash, first thing you do, turn off the infusion, number one, okay? Get rid of what's causing it. As I said, that apheresis, it looks something like that machine up there in the picture. It's like a kidney dialysis machine, but it just removes what you want. In the case of thalassemia, it's that iron. And if they have any of these hematological things, these children are going to get a bone marrow aspiration. We need to look at those blood cells. Be honest with these children that it could hurt a little. We do numbing on the outside. We numb as we go in. We do all of these things to prepare them, but it's going to hurt a little bit. And if you've ever seen a bone marrow, there's a crunch when they take the thing and put it in there. So please let them know they're going to hear something too. Be honest. And your kid, especially if they have a condition, because they're going to get it again, and you don't want them to have a misunderstanding. So if two parents have sickle cell trait, what is the chance that each child will have sickle cell anemia?
25%.
Absolutely. Thank you so much. Now, neoplastic disorders. Well, when we talk about neoplastic disorders, mostly those cancers are blood or blood-forming organs, lymphomas, leukemias. Now, leukemias is the white blood cells. They're immature. They don't work. So your white blood cells don't work. What do you think a sign and symptom you might have leukemia is? Fever, infection, right? That's number one. And then if you have this overwhelming infection, your red blood cells are being eaten up. And your platelets are being eaten up because the body's trying to take care of itself. So you're tired, you don't feel good, and you usually have bone pain to go on with it. It is white children, less than 15, in boys greater than 1, and most of these children are ages 2 to 5. So it's that, oh my goodness, my kid's 3 years old, has leukemia. And it's like a 2-year type battle with it. So it's a lot of struggle. But today, kids do well. Now, leukemia, there's 2 types. There's the ALL, lymphocytic leukemia, and AML, myeloid leukemia. So AML is harder to treat than ALL. So if you have to have leukemia, hopefully it's ALL. As I said, it's those immature white blood cells. It doesn't work. The body's being destroyed, the liver, the spleen, and it does attack the body and works quick, to deplete it of all the supplies. So what do we see? Now, my next door neighbor was complaining of being tired, was having bruising, her knee hurt, and she had a fever. Didn't feel good. Mom brought her to the ER. They did a CBC and a blood smear. Her initial white blood cell count was 0.1. What's a normal white count? A 5, 6, below normal. So she had no white cells at all. So she had to go through the whole process of leukemia and the treatment. You do a lumbar puncture. We want to see if it's in the central nervous system. And then we're going to do bone marrow. We want to see the cells that are there. And again, be honest, it hurts. Now, once we decide the type of cells, we decide what sort of chemotherapy you want to give. We start with the induction therapy of chemotherapy. Now, this is actually kills everything. So it's 4 to 6 weeks, and our goal is remission, which means kill all the cells. You're also killing good cells too, okay? But the rest of these phases of therapy is to get those little stragglers that are still there to make sure that they're completely gone. So that first 2 months is hit them hard with chemo. Let's put them in remission, and then let's go and get rid of the other stuff. Put it in intrathecally, and then going in to get all those resistant cells and putting them on maintenance. Now, many times we give a hematopoietic stem cell transplantation. Now, when we give blood, there's a blood type, right? If you're A positive, you get A positive blood. Well, in this case, there's not. It doesn't matter if it's positive, matched, unmatched, relative, no relative. We know that if we give the patient's own stem cells back, it's the best, or sibling, okay? But we can use anything if we need to. Now, if we give our patient's own cells, it's called an autologous stem cell transplant. Autologous, automatically mine, it's the best, okay? Allogenic is everybody else, everybody else, all of the others. That's how I remember it. All of the others, everybody else. Autologous, automatically mine. That's how I remember the types of transplants. When it's mine, usually this is the umbilical cord blood. We have that ability to save it now, and many parents have the financial capabilities to do it, but it is expensive. So not everybody has that ability. And there is, graft versus host, it's called, that rejection. It can happen, and it does happen. So again, this is a long-term treatment that we're going to be doing. We need to keep that kid on our side. We don't want them scared afraid, crying to come in the hospital. We want them to come in and say, oh, there's my nurse, to have that comfort because, they're away from friends, family, school, and it is very difficult. They're being poked and prodded, they're losing their hair, they're vomiting, they feel horrible. We want to really prepare them. The complications, of course, infection. We're wiping out their immune system with chemotherapy. Plus, leukemia means there is no immune system. And because all of the other components of blood are being eaten up with this disease and infection, you're going to see hemorrhage. Hemoglobin, hematocrit, platelets are low. They're getting transfusions. They're getting platelets, and they're anemic. They're tired. They don't feel good. They have no energy. And, chemotherapy is really caustic. Nurses must be trained. I want you to know that many nurses, especially specialized pediatric oncology nurses that give chemotherapy, can get like $25,000 bonuses to sign on to hospitals. Probably one of the most monies that you can get for a specialty in nursing. Now it is hard. You have children that die, right? But don't think of it that way. What did you do for the child and family while they were alive? I've told you, I worked in the cardiac ICU for many years, and I had many children die on me. And I sat there and cried and bawled with the parents, gone to funerals, bawled with the parents, and it's okay. But 20 years later, many of these mothers and fathers are still in contact with me, checking up on me on Nurses Week and my birthday or a holiday. So it can become something beautiful. So it's not that a kid dies, it's what did you do for them and their family, at you as a nurse. You do make difference. Prognosis depends on where was the white count. Was it 0.01 or was it 0.1? Makes a big difference. How old were they? Was it the ALL or the AML? Male or female makes a difference. And what is your blood type? As I said, you get a lot of transfusions of blood and platelets. If you have a rare blood type, you can't get the blood as quick as you need it, and that could cause problems. So you got A positive, you're good because it's common. Now, more things about cancer. How do we treat these children? There's chemo, there's radiation, there's surgery, and there's combinations of all of them. If we have a child with cancer, if we catch them early before they become an overwhelming sepsis, before they absolutely bleed out because they've wiped out all of their platelets and their blood, we can do good. I mean, children who are complaining of those things, just like my next door neighbor did and got treated quickly, she did well. She now has a PhD in psychology from the University of Miami. She's done well. So it's because the parents got her quick, got her treatment, and they worked through it. And me and her mother would hug each other and cry together all the time, but it was okay. We got her through it. Some of the things that happen is something called septic shock. Now, what do you look for? What are those signs? Well, we know there's no white cells, but neutrophil counts become a big deal. Neutrophil count should be well over 1,000, 2,000. But you see him at 500, 400, this kid has no immune system. So there's nothing fighting infection. They've got no white cells. So these kids can go into septic shock and die just like that. And I'm telling you, just like that. You can't bring them back. So if you're on the nursing unit and you've got 4 patients, all have leukemia, but one of them has a neutrophil count of 500, 400, that's your first patient you're going to look at. And you're going to make sure you're washing your hands and wearing a mask if you sound like me, okay? In fact, I wouldn't take care of this kid today. These children get broad spectrum antibiotics, they get cultures, and again, preventing infection and using good septic care, making sure we do those things, wearing gloves, so important. Hemorrhage, as I said, their blood counts are all over the place. So make sure that, again, protecting them so that they don't bleed. They shouldn't be riding a bike, playing contact sports. I mean, no, these shouldn't, but not every parent understands that. So we need to make sure that we tell them, okay? Some parents need explicit instructions. And again, giving them the transfusions as they need. And again, they're going to be anemic, as I said, because it's chronically eating up the cells, due to what's going on in chemo. So remember, they're tired. Limit activity, do cluster care, make sure you're not overworking them. Nausea and vomiting, we're treating before we give chemo today. When I first started nursing, I couldn't give an antiemetic till after they vomited. So I used to say, oh yeah, they already vomited. And I'd go get the medicine and give it to them because I knew they were going to vomit, some of these kids. So we give it before, which is great. We're using cannabinoids now. And I've seen many documentaries. There's a great one on Netflix right now that I was watching last week and showing all the great things. I mean, they even use it with seizures with children. And it's one of those controversial things, it's up to the parents and the physician to decide what they want to do. They're not going to eat. Their mouths are swollen. They're bleeding gums. They can have mucosal irritation from the mouth to the anus. They hurt. They don't want to eat. So we need to measure nutrition. How do you measure nutrition? Daily weights, right? We want to make sure their height, their weight. We know that if they're losing weight, something's going on. We need to change something. And their diet, because they're not going to eat much. High protein, high calorie, full fat. We want to pack in the calories, pack in the nutrition, because they're not going to be eating too much. As I said, they're going to be irritated, mouth to anus. Whatever we can do to decrease that irritation, we will do. And from the foods to sitz baths, whatever. And we're going to be giving pain medicine. Pain medicine causes constipation. These children have low platelets. They have a chance for bleeding easily. If they push down, bear down to have a stool, they can stroke, right? So we want stool softeners. Keep that stool moving, but make sure we keep that pain under control. They can bleed anywhere, in their urine. And of course, they're gonna lose their hair. I've seen fathers and brothers and whatnot shave their head. I mean, what I used to do for these kids is I used to go get these little rolls of ribbons, all different colors I could find. And I would go into the little girl's room. I say, so what color ribbons are we going to be wearing today? And I'd have her help me make a little headband or a little bow or just stick it with tape on the head, whatever. And that girl made her feel special because she had the color ribbon she wanted for the day. It makes a difference. Steroids. Think of that puffed up steroids, that, cushion-oid thing, especially with adolescents, body image, they just feel swollen. Make sure that if we're putting gowns, that we put bigger size, that they're not tight. Make sure we tell parents, get a larger size pajamas, because you ever have a shirt that's too tight and you're pushing and pulling it because maybe a little fat roll is going to hang out. Well, these kids feel the same way. So bigger jammies, they'll be more comfortable, feel better. Most of these kids are sedated, giving a little bit of midazolam, some Versed, but remember, teach them, let them know what's going on, and make sure the physician is using all the numbing things we can, and always get child life involved and distraction. iPads are amazing tools to use. Pain management, we know about narcotics. Don't forget about Tylenol. Tylenol works really good. But also remember hot packs, cold packs, positioning, distraction, coloring, playing cards, checkers, music, all that stuff. Use it all. It's all part of pain management. Okay, now let's do lymphomas. There's two types. and they're same name, but they're different in presentation. Hodgkin's disease is lymph nodes, but it's above the clavicles. It's in the head, and it looks like this. Big swollen lymph nodes. These kids will have a fever. They're not going to eat. They don't feel good. And they've got these big things on their neck. They don't hurt. Enlarged lymph nodes that do not hurt, not painful. Okay. Brings them into the doctor, and they'll look at these children, see these nodes, and they're going to be doing that CBC. They're going to be doing a CRP. A CRP is a C-reactive protein that measures inflammation. ESR, SED rate, measures inflammation. These things will get us an idea of what's going on. And then they'll do a lymph node biopsy. They'll put them to sleep or knock them out good, and they'll put a needle in, and they'll look for the presence of Sternberg Reed cells. And that will show us it's Hodgkin's disease. We do radiation, chemo, and these kids do great. Now, do you see those little marks? Those are for radiation. Never wash them off, because that's where the gun points to make sure it's going to the same place all the time. Problem with Hodgkin's disease is a high risk of infertility. Many of these girls and boys cannot have children after this, but they're alive, okay? That's the trade-off. Now, non-Hodgkin's is not up here and big nodes. It's diffuse little nodes all over the place. That's the difference, okay? Treated almost the same. They're going to do the biopsy. They're going to look at it. They're going to do x-rays to see where all those nodes are. And they're going to be given radiation and chemo. Same thing like leukemia, induction, consolidation, et cetera, et cetera. And these kids we can also bring back from it. So Hodgkin's, big clavicles up, okay? You're going to be seeing big nodes. They don't hurt. Non-Hodgkin's, diffuse all over the place. You don't really see them. Same symptoms. Brain tumors. Well, brain tumors, benign, malignant, don't matter. How would we know a kid was having a brain tumor? Well, there's usually two symptoms they talk about. Well, this thing is occupying space. It's causing pressure, and it's causing increasing symptoms of worse and worse headaches. And the headaches, sometimes they're woken up at night from them. So it's headaches, and they're getting worse, and it's hard to treat. The second thing is because the pressure in the brain, vomiting, not related to eating at all, and vomiting, which gets worse and worse. Those are the two symptoms you see with it. With brain tumors, they're going to do radiation, chemo, shrink it, do surgery, and get it out. The problem with brain tumors postoperatively is nursing care. Now, you've taken out a piece of chunk of tumor brain, okay? There's a space left there. Do you lay them on that side? Do you lay them on the other side? Do you elevate the head? Do you put it down? What are you allowed to do? Make sure you check the doctor's orders. Another thing, because it's brain, fluid management, intake, output are so important. You do not want to overhydrate because of the brain, okay? So fluid balance, very important. And again, pain management, take care of the child, let them know what's going on, and the family too. Now, neuroblastoma is very rare. We mention it because it's one of those tumors that we can see. It is a tumor that comes off of the kidney in the abdomen, but you don't see it there. It's like all of a sudden the tumor gets bigger and it crosses the midline of the belly, but you don't see it until the eyes start bulging, exophthalmos, maybe bruising around, or you see some neurological dysfunction. And it's already metastasized because it's in the belly, it's already gone to the brain. The outcome of these children is not good, okay? Because it's already metastasized by the time we give them a diagnosis. So again, they will try to do surgery. They'll try to take care of it. But again, I'm telling you, outcomes are poor. And then the next type is what we call osteosarcoma, which is a bone tumor. When we think of bone tumors, we think of the femur, which goes from the hip joint down to the knee, and the whole bone has to be taken out. We will see a kid who's starting to limp, complaining of pain, that gets worse, and then it's cancer. So you start seeing that being tired, you start seeing anemia, weight loss, you'll see it swollen, and now, all right, let's do an x-ray, CAT scan, find out, do a biopsy, and we find out it's osteosarcoma. Many of these are adolescents in the osteosarcoma of the femur. How do we treat it? Well, we're going to give chemo, and then we do surgery. The goal of surgery is to salvage or keep the lower leg and attach it up to the hip. Why? If you take the femur out, it's the whole leg. What are we going to attach a prosthesis to? How is that kid going to be mobile, right? So if you see that bottom left picture, he's looking forward, but that short leg is pointing backwards. They make a prosthesis that will fit on there, and now this child can be mobile. Goal is to save the limb, salvage the limb. On occasion, they can't, and an amputation is done, because you can't just take out a femur bone. There's nothing left. You've got to take out that whole bone. Wilms tumor. African-American males ages 3 to 5. And this is a tumor that comes off of the kidney. It is extremely fragile and can metastasize with just touch. These are not biopsied before surgery or radiation or chemo. We do not touch these abdomens because it's so fragile. I saw it once. When they had that Haitian earthquake back in, about 10 years ago, one of these boys we saw down there, because our team had gone there, and through some religious group, we got him up to the hospital, and some religious group picked him up at the airport, brought him directly to me, and I'm in triage. I said, so why is he here? And they go, I don't know. Here's his papers. They told me to bring him here. And I went, okay, well, where do I put him? It's, what's going on? So I'm like, okay, I've got to be a nurse. I need to do an assessment. So I did. I did vital signs. This kid speaks French, but I got him calm, gave him a sticker, did all that good stuff, did his vitals. I looked at his eyes. They were fine. Listened to his chest, felt his abdomen, listened to it. The left lower quadrant had a softball-sized mass. I don't know why I knew, but I knew it was a Wilms tumor. Something on my mind, I read about it somewhere, and it was. So what did we do to this kid? Well, we did surgery pretty quickly on him. We had a note on the chart, the note on the kid's forehead almost. Do not palpate that abdomen, because it will be fragile and go in the peritoneum and cavity, and that's the spread. That's metastasis now. So we were able, they have to do a big incision because they have to get the whole thing out without manipulating. A lot of things will be a little hole and pull it out and squeeze it, right? Not this one. That is an incision that this kid would look like. It's a big one. And they pulled the whole tumor out. So post-operatively, you've taken a tumor off of a kidney. So watch urinary output. You've gone through the intestines to the back where the kidneys are. You've manipulated that GI tract like crazy. So monitor bowel function. And also, because of all of that, always worry about infection. The kid went back to Haiti. The kid did well. And we heard from him a couple of years later. I went to the floor where he stayed, and he sent them a card and thanked them, which I thought was pretty neat. Rhabdomyosarcoma is basically places like the eyes, underneath the ears, in the nose, the gums of the mouth. And this is a cancer that comes up, and it's really cancerous and requires long-term chemotherapy treatment and surgeries. Retinoblastoma is that white looking eye that you see right there. I saw one 8-month-old little girl, and I didn't know what it was. So of course, I'm going to read. This is what I always did when I didn't know. And this looks like when you open the door at night and you look in the backyard and you have a light on and you see a cat or a dog or a deer or a bear and you see their eyes glow. Well, that's what their eyes look like. And it's the retina has cancer in it. Treatment, you got to remove the eye. Okay, the whole eye comes out. Irradiation, chemo, take the whole thing out. Again, there's that radiation thing. Don't wash it off, leave it there. One of the things when we see this, and we're doing a history to determine how to treat this kid, is we need to do a detailed family history about eye signs and symptoms. How long have you seen this? When did you first see it? Because this can metastasize quickly. Well, if this just happened, you just saw it a week ago, that's one thing. If it's been there for 2 months, then they need to search the whole body for metastasis. So the quicker we get these, the quicker the kid does well. The eye comes out and they live, they have one eye, but they do okay. But you can see, they have to have this prosthesis. I was telling my other class, I had a kid in high school, a boy, used to take his eye out and roll it around on his desk to try to freak us out. And then he'd take it, put it in his mouth, lick it and stick it back in. And I was like, thank God I wanted to be a nurse. Germ cell tumors, we think about testicular cancer. Women check their breasts, men should be checking their testicles. Had an 18-year-old boy come in, testicular pain. When we checked the testicles before putting him into the back in the ER, it was already the size of a softball. We did X-ray chest, a chest of the X-ray of the abdomen. He already had metastasized everywhere. It metastasized really quick. He said it'd been there for a month, had to be there for a couple months. So again, early treatment is the best. Livers, they regenerate. So these are easier of all of them because there's a piece left, right? Chemo, and yes, it is surgery, but they do well. So cancers, they survive really well today. If I look back at my career of over 40 years and what they did and they died, and now everybody's living and they have productive, great lives, it's amazing. So there's been so many changes. And on Facebook, you see these pictures of adults and children cancer-free. It's like, I'm hoorah. I think it's the best thing there is. So those are the PowerPoints for today. Interesting topic, isn't it? I had a lot of stories for you tonight. Who wants to win a Kahoot? There we go. Come on, Crystal, you too. Put your hand up. Say hoorah. Okay, there we go. Let's do it. Amoy, you're going to win tonight too. I know you can. Megan, are you still with me?
I am still here. I was
All
just
right.
eating, so I didn't
All
want
right.
to jump in online.
I just was making sure. Yeah, the dean came on last night to check me out, see how the students were doing. I was like, oh, you're checking up on me. I don't mind. She can come whenever she wants. I have nothing to hide. Who's else going to play tonight? One 0970. All right, here we go. Good job. Let's go. We'll be out good. I think I did it good tonight. Which statement best describes a neuroblastoma? Remember, where does it start? It starts on the kidney, right? And it gets bigger and bigger. And then all of a sudden, you see all of these signs. The eyes They start to bulge, tear, bruising around them. It's usually after it's already metastasized. Neuro means it's up here, but it's already started in the belly. It's already metastasized. Thank God it's rare. What is the priority treatment for a newborn of an HIV positive mom? I mean, I used to always think, in the beginning in the 80s, mother had HIV, the newborn, it was a death sentence. That's what I always thought, right? But today, no, because our goal is to improve that infant's immune system, and we can convert that kid to no HIV. What are symptoms of sickle cell anemia? So you're going to see hand, foot swelling. Remember, it could be headache, could be eye pain, chest pain, vision, delayed growth, but mostly pain and swelling is the big thing. Treatment? What? Sickle cell anemia affects which cells? I mean, which cells are sickled? It's all about anemia. Anemia is all about red blood cells, okay? So it is red blood cells. What kind of hemoglobin and hematocrit would someone with sickle cell have, and why? Well, we know there's anemia, but why is it anemic? Decreased production, decreased, they die quicker, destruction, what is it? Remember, there's 3 ways we get anemia. And it's lower. These kids have lower because these cells die quick. Just like thalassemia, the cells burst, they die quick. Sickle cell, die quick. There's plenty cells, but they die. What is the treatment for sickle cell anemia? IV fluids, #1, right? Medication, pain, and antibiotics, blood transfusion, and maybe a bone marrow will help. What is the reason children with iron deficient anemia are easily tired? What's the reason children with any type of anemia are easily tired? I don't have oxygen. I don't have iron. I don't have red blood cells. Very good. Aplastic anemia includes a depression of which cells? So this anemia is a depression, and it's red cells, white cells, and platelets. Very sick child that requires immunosuppressive therapy, treated just like leukemia. Most common type of anemia is what? Iron deficient anemia. Iron deficient anemia. It's nutritional. You just don't eat right. Many people don't eat right. What causes promiscuous anemia? And it's all about that intrinsic factor B12 deficiency. It's another name for it. Which symptom is the single most common symptom of anemia? Usually what brings them into the doctor. This isn't my kid. What's going on? Again, what is anemia? Low red blood cells, no oxygen, no iron, no energy, fatigue. Very good. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Remember, this is those rectangular shaped cells, and they burst. Their cells are bursting and bursting. They need blood transfusions to live. They also need what? They need iron chelation therapy. What's in a red blood cell? Okay, they're bursting. Iron and oxygen. What is the worst thing? Iron, it becomes toxic. It needs to be removed. And then they need transfusions to live. What lab values would you see with hemophilia? I mean, we want to know what all the factors are if we determine it, but what's that easy lab value we could do to look at? It's the PTT is prolonged. That shows bleeding, right? Prolonged PTT means you're bleeding. It's like you have too much heparin. You worry about bleeding, right? But the other parts, components, your prothrombin, platelets, they're normal. And once you see that prolonged PTT with no reason why, then you look for what factors that you need to replace because you know you have hemophilia. Priority treatment for a child with sickle cell crisis is what? Well, sickle cell crisis is when the cells are clumped up. We need to do what to get the clog through? IV fluids, push it through. And we're going to have pain medicine in the other hand, and we're going to have a hot pack to put where it is in the other hand. Very good. What is immune thrombocytopenia purpura? ITP. What does P mean? Platelets. ITP. Think platelets. Not enough. Immune. How do we treat it? Thrombocytopenia can cause the following symptoms. Thrombocytopenia is low platelets. They're thrombocytes that cover their platelets. It's like that little Band-Aid to stop bleeding. And it's that petechia, that little purplish little hemorrhages that you see. Arms, legs, could be anywhere. And of course, bruising and the nosebleeds is usually what brings them in. I'll multi-select. A child with hemophilia has falling, the knee is swollen, painful. Treatment would include what? Remember, the blood in that joint can cause that joint to become crippled over time. So we need to stop it as soon as we can. So we want to RICE, right? Rest, ice, contain, elevate. So elevate it and cold packs. A hot pack's going to dilate the vessel and do what? Cause more bleeding. You want a cold pack. What is the priority nursing action for suspected blood transfusion reaction? You see a fever, you see a rash, or you see them, their jugular veins are distended and they're breathing heavily. What do you do first? Turn that transfusion off and then let the physician know. Good. A child is admitted with neutropenia, which nursing action takes priority. What is neutropenia? Neutropenic, what does that mean? Means the child's really up and susceptible to infection, right? Don't have enough white cells to fight infection. Number one is just hand washing. Hand washing, number one. Which symptoms would a healthcare provider expect to see with a child with leukemia? This is so classic, like my next door neighbor, the girl that I talked about, who's now a PhD. Remember leukemia, you have no blood cells, you have no platelets, you have no white cells, and you're going to see that bruising because the platelet's going to be low. They have no red blood cells, no oxygen, no iron. They're tired and they have bone pain. Very good. Your child has leukemia and the recent lab values have a platelet count of 10,000. What are you going to do? What is that telling you? When you don't have platelets, you are so apt to bleed. So bleeding precautions is number one. Absolutely. A multi-select. A child's placed on bleeding precautions for ITP. What interventions would the nurse do? So you know ITP is low platelets. So bleeding precautions, which one of these do you look for? The answer is all the above. And remember I said at times they sometimes will treat with corticosteroids. No injections, look for bleeding, monitor that CBC. You know, that's what we do to prevent them from losing any more platelets. A child with Wilms tumor, which action by a nursing student causes faculty member to intervene. Remember that's that kidney tumor. Remember this tumor off the kidney, like that little Haitian boy with that softball sized tumor, it's highly fragile. So do not palpate it. So if you see somebody touching it, get their hands off. Say, I'm sorry, but don't touch that tummy. Cancer of the body's blood forming tissues, including the bone marrow, is called what? Cancer of the blood and bone marrow. It's called leukemia. Very good, guys. A child with leukemia has a fever of 100.5. What should they do? When you talk about leukemia, you already have no white blood cells. And now you have a fever, even though it's barely a fever. They need to treat it now before it becomes septic shock, right? Or else it will be because they have nothing to fight it. Get medical attention. Child is having a bone marrow aspiration. What should you tell the child? It's going to hurt, absolutely, but they're going to do everything you can to make it as little as possible. And as long as you say that, that's all they really want to know. Most common clinical manifestation of a retinoblastoma. And it's called cat's eye reflex. Reflex. It's that white glow. It's very, when you see it, you'll never forget it. And it looks like the picture that I had here, and it's also on your PowerPoint. Your child has been diagnosed with a retinoblastoma. What information is important to get? When you're doing the assessment, what do you need to know? We want to know any history about the eye signs and the symptoms seen. We want to know how long you've seen that little white glow. Makes a difference in treatment. A goal of surgery for a child with an osteosarcoma is. Remember, osteosarcoma is the cancer of the femur bone. We're going to try to salvage that limb. Take the lower leg and put it up so that there's somewhere to put a prosthesis. Most of the time, we can do that today. True or false? Autism causes, immunizations causes autism. You know, autism is not diagnosed usually till about 2 to 3 years old. And we know we give immunizations like the varicella, chickenpox, around 2. But it has nothing to do with autism. The physician who made that statement does no longer practice. He has no license. And that research study was false. A child complaining about skin markings for radiation therapy should be told what? You know, those purple marks, why are they there? So they're there because we need to know where that radiation gun goes to. So it must remain so we do the same place all the time, because that's when it makes a difference. I'll multi-select. Nursing care of a patient with immune thrombocytopenia purpura, ITP. How do we treat it? P platelets, low platelets. There's not a clog. There's just low platelets and you bleed. You do not need IV fluids. Remember I told you? You would understand why I said that. Because sickle cell, you need fluids. ITP has nothing to do with fluids. It's bleeding precautions, seeing if they're bleeding, and don't give IM injections. Monitor their CBCs and give corticosteroids as needed. IV fluids, they don't need it. There's nothing blocked. There's nothing causing anything there. We don't give IV antibiotics, nothing. When distraction is used, it helps what? So when you do distraction on a kid, they're not going to think about what's going on. They're going to forget about it. And if for a moment they don't hurt, you know, it works. And it works really well. What assessment question needs to be asked to a child with possible rheumatic fever? I threw in some questions from last week's information, just trying to see if you remember these things. What causes rheumatic fever?
Pharyngitis.
Absolutely. Absolutely. So how do we treat rheumatic fever? We treat the strep. We give them antibiotics for at least a month, if not longer. And all of these symptoms, including that chorea, shuffling, wobbly gait, all of that will go away except heart valve damage. So yes, very good. Signs and symptoms of asthma. All of the above, right? Expiratory wheezing, croup, inspiratory stridor, asthma, expiratory. The air gets caught, can't get it out. Very good. A multi-select. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? Well, the swelling is going to be a part of it. Headache, we're going to worry about. Stroke, right? Chest pain could be, a chest discomfort thing. Has nothing to do with healing. So sores has nothing to do with sickle cell. Absolute contraindication for nasotracheal suctioning include which of the following? Whenever we have a question like this, what in there would cause us not to want to create more swelling or inflammation, right? If you already have an oral pharynx full of swelling, that's when you don't want to do it. And it's all the above, right? Makes sense. Iron dextran is given via which route? We would use this in iron deficient anemia sometimes. Remember, this stuff burns and it stains the skin. So we're going to be giving it IM-Z-Track because we don't want it staining the skin or burning, and it does both. If a child was to receive their own bone marrow, this is called a blank transfusion. Remember those things I told you. Automatically mine is mine, right? Allogenic is everybody else. So autologous is your own. Very good. What cancer may present with painless, firm, enlarged cervical nodes, which means up here? And that is Hodgkin's lymphoma. Remember, non-Hodgkin's is diffuse all over, not just these big things here. You won't see them like you see Hodgkin's, and they don't hurt. A multi-select. When teaching about sickle cell, you would include what? Now, we can prevent a lot of crisis if we teach our children and parents and adults how to take care of themselves. We should never assume that they know. We want them to drink lots of fluids. We want them to be warm when it's cold outside, so we keep the blood flowing. Pain medicine early. And again, any fever, get to the doctor immediately, get care. Thalassemia major, Cooley's anemia, is treated primarily with what? Again, remember, thalassemia is those rectangular cells, red blood cells, that burst and spew iron and oxygen into the blood system. And we worry about hypoxia and iron. It's treated only with blood transfusions. And we're never going to give high iron, in fact, nothing iron, because these children need the iron removed from their body. Multi-select. What are opportunistic infections of HIV? Candida and PCP pneumonia. Urinary tract is a normal infection and rashes are a normal thing. Candida, yeast, and PCP pneumonia is respiratory. I'll multi-select. Treatment of osteosarcoma includes remember, osteosarcoma is the cancer of the femur bone. We'll do chemo, and we hope we can salvage the limb. There's a place for a prosthesis, but sometimes we can't. We do an amputation. Stem cell does nothing for this patient. There's a tumor, it needs to come out. Stem cell is nothing. I'll multi-select. Who are the best donors for bone marrow transplantation? I mean, you know, number one, it's yourself. That is the best. But the second one is siblings. Mom, grandma, no. Siblings and yourself are the two best ones. Good job. What is the most common opportunistic infection with children with HIV? And that's called PCP pneumonia. That's the most common of all of them. Yes, you can get candida, but pneumocystic pneumonia, that's the one. What would you consider to be neutropenia or a low neutrophil count in children? And remember, neutropenia in some children can be deadly, less than 500. It's usually over 1,000, 2,000, but when we consider it really low, it's 500 and less. That's your priority nursing patient, if you have a patient like that. A primary characteristic of a brain tumor is what? What do you see? Remember, there's this thing growing in the brain, occupying space, creating pressure, and it's those symptoms that start that become worse and worse. A headache that becomes worse and worse, vomiting that gets worse and worse, and even headaches that they awake from sleep from. That's another one of the symptoms. The optimum treatment for osteosarcoma is we want to salvage that limb. Okay, we want the piece of the limb to go up to where the hip is so we can put a prosthesis. Okay, that is the goal. Amputation is the last thing we want to do, but salvaging, that is what we really want. And last question. A child is receiving the induction of chemotherapy. What does that mean? Remember, that's the first stage of the 4 stages of chemotherapy. It's that initial 4 to 6 weeks of chemotherapy with the goal of remission. The other stages are to get those outliers, those cancer cells that we didn't get. Really good. We made it on time tonight, guys. Number 3, Amber. Good job, Amber. Whoop, whoop. 2 is 110970. And number 1, JDY. Is that like a Judy?
Jada.
Jada, good job, Jada. CJ, it's my grandson's initials. I'd like you to sign your attendance attestations. Make sure you get that done. Remember that there are those reviews this week. I do mine on Thursday at 5 a.m. I will be posting them as soon as I get them. So thank you for a great night. Tolerating my coughing. I'm
Professor,
sorry. Yes.
that's the only review that you're gonna give us?
5 o'clock
Thursday?
on Thursday, and I will be posting it.
Okay, because
Professor,
we
it's
have
you
class
said
on
Any
Thursday.
questions? If you have any
You said
questions
5 a.m.?
regarding and 5 p.m. Thursday.
Oh, okay. Okay.
If any questions come from that review, you don't get it, send me a message. I can always meet with a bunch of you if I need to. I am more than willing. Okay.
Okay. The last thing, Professor, I wrote 2 times